Hello friends, this is Dr. Ganga, your nephrology educator at Prep Ladder. Today I'm here to discuss with you about vasculitis. So I'm going to divide this into two parts. The first part is we are going to deal with what is vasculitis and what is ANCA vasculitis. The second part I'm going to be discussing the treatment, which is mostly KDIGO guidelines, and also the other type of vasculitis other than ANCA vasculitis, right? Let's get started. So I have divided this session into the following headings. So first, we are going to see what is Chapel-Hill classification, what is the renal involvement in vasculitis, what is pauci-immune glomerulonephritis, what is the pathogenesis of this pauci-immune glomerulonephritis, what are its clinical features. Then we are going to learn in detail about what is ANCA, and finally we are going to end up with quick revision, which is nothing but I brush upon the topics or the questions which have been asked in previous entrance. Okay. Now, let's start with Chapel-Hill classification. So, in 2012, Chapel-Hill classification was created to classify vasculitis, and vasculitis was classified into three major sections based on the size of the vessel. So, first one was the large vessel vasculitis, the next was medium vessel vasculitis, and third is small vessel vasculitis. Okay, so based on the size of the vessel, it was large, medium or small. So with respect to kidney, how can we understand this? So large vessel vasculitis meaning aorta is getting involved, right? Medium vessel vasculitis means including renal artery. Then renal artery enters the kidney, becomes interlobar artery. Interlobar artery becomes arcuate artery. Arcuate artery becomes the interlobular artery. So until here, you are going to see medium vessel vasculitis. So in the kidney, the main renal artery, the interlobar artery, the arcuate artery and the interlobular artery. So all these things are going to be medium vessel vasculitis. And small vessel vasculitis is mostly the arteriole and the glomerulus. So there can be some overlap with interlobular artery being involved with small vessel vasculitis. Okay. So this is how it's classified: large, medium and small. Then large vessel vasculitis based on if patient has a granulomatous arthritis in a patient more than 50 years, then you call it as giant cell arthritis. And if a patient has granulomatous arthritis which is less than 50 years of age, then you call it as Takayasu's arthritis. So if a patient has granulomatous arthritis more than 50 years, it will be giant cell arthritis. And if the same patient has granulomatous arthritis less than 50 years, it will be Takayasu's arthritis. Okay. So that is large vessel vasculitis. Now coming to medium vessel vasculitis. Medium vessel vasculitis, you can classify it based on whether there is necrotizing arthritis without mucocutaneous lymph node syndrome. Okay. So where the mucocutaneous lymph nodes are not involved, but it is necrotizing arthritis. Similarly, if there is necrotizing arthritis with mucocutaneous lymph node involvement, then it becomes another. So the disease or the medium vessel vasculitis where mucocutaneous lymph node involvement is not there, it becomes polyarthritis nodosa. And in which mucocutaneous lymph node involvement is there, it's Kawasaki. So large vessel vasculitis was classified based on age. Medium vessel vasculitis is classified based on involvement of mucocutaneous lymph node. Okay. Next, coming to small vessel vasculitis. So small vessel vasculitis is classified is based on whether immune complex is deposited and something is detected in the immunofluorescence or not. So first classification is immune complexes deposition in the vessel wall with immunofluorescence staining for immunoglobulins. Okay. Or there is circulating anti-neutrophil cytoplasmic antibodies, that is antibodies against the antigens that are present in the cytoplasm of the neutrophil. So there is neutrophil. Assume this is the neutrophil. Okay. So here there are antigens, right? So there are circulating antibodies that are present against the cytoplasm of the neutrophil. Okay. So that is called as ANCA. So with this antibodies will be there and there will be paucity of vascular immunoglobulin staining, but you can't find these antibodies bound to the blood vessel. That is why you call it as ANCA associated vasculitis. Now further, based on this classification, so we learned that there are two classifications, right? One is immune complex mediated and another one is ANCA mediated. Now ANCA can be further classified into three types. which is microscopic polyangiitis, MPA, granulomatosis polyangiitis, or which is commonly called as vaginous, EGPA, eosinophilic granulomatosis polyangiitis, or which was called earlier as Churg-Strauss. Okay, so it is divided into three conditions. So what are the features in microscopic polyangiitis? There's going to be no asthma, or there is not going to be any granuloma. Whereas in GPA, granulomatosis with polyangiitis, there's going to be granulomas, but there's not going to be any asthma. So that is a difference. Okay, in MPA, you are going to see no granulomas. But in GPA and in EGPA, you are going to see granuloma. Okay. So what happens is, here you are going to see granulomas with no asthma in GPA. Eosinophilia, asthma and granulomas you are going to see in EGPA. So this is about the ANCA vasculitis. Now coming to the immune complex. Immune complex, there are 4 important diseases which can deposit immune complexes and cause vasculitis. So first one is SLE, which is common, or rheumatoid arthritis. The second disease which can cause it is IgA nephropathy. The third which can cause it is cryoglobulinic vasculitis. And fourth can be other immune complex vasculitis, which we are going to learn. So the major ones causing these are SLE and rheumatoid arthritis causing vasculitis, IgA causing vasculitis, cryoglobulinemia, and other immunological diseases causing vasculitis. So in this thing, we learned the Chapel-Hill classification, in which vasculitis is classified into large, medium and small vessel. Large vessel can be further classified into based on the age. Okay, if it's more than 50 years and granulomatous arthritis is there, we call it giant cell arthritis. Less than 50 years and granulomatous arthritis was Takayasu. Similarly, when we come to medium vessel vasculitis, which can involve anything from the renal artery to the interlobular artery, that if it is associated with mucocutaneous lymph node involvement, it becomes Kawasaki disease. If there is no mucocutaneous lymph node involvement, it becomes polyarthritis nodosa. Then coming to the small vessel vasculitis, you classify it based on immune complex or ANCA mediated. Immune complex, again in immunofluorescence, you will see that immune complex deposition is there. So it will be positive. But in ANCA, you don't find immune complex deposition. It's basically neutrophil mediated. Okay. Though the antibody binding to the neutrophil cytoplasm antigen is the main pathogenesis, further all the destruction happens because of neutrophil. So that's why you will not be able to find any antibody in the blood vessel. Now coming to the conditions which are immune complex mediated vasculitis, mostly it is SLE, rheumatoid arthritis, IgA nephropathy, cryoglobulinemia and other causes. Okay. Similarly, in ANCA associated, you have 3 major, which is microscopic polyangiitis, granulomatosis polyangiitis and eosinophilic granulomatosis polyangiitis. Out of this, the peculiarity is microscopic polyangiitis does not have granulomas. Okay. This is the same classification. Again, here you are seeing large vessel vasculitis, giant cell arthritis, which is more than 50 years, Takayasu's arthritis, which is less than 50 years. Medium vessel, polyarthritis nodosa, it is no mucocutaneous lymph node involvement. Kawasaki has mucocutaneous lymph node involvement. Then coming to the small vessel vasculitis, it is circulating ANCA associated, which is microscopic polyangiitis, GPA, EGPA. There is another class which is drug induced. I'll come to it, in which drug induces vasculitis, and in those patients ANCA will be positive. The second category is immune complex associated. So we learned cryoglobulinemia, IgA nephropathy. We also learned SLE, rheumatoid vasculitis. Okay. Now the other things that here I told, other sources of immune complex. So those causing vasculitis is anti-GBM disease. This we know as dual positive disease. Any infection-induced immune complex vasculitis like hepatitis B and hepatitis C. Because we know that they can cause serum sickness, they are capable to cause vasculitis. Again, hypocomplementemic urticarial vasculitis, Behçet's, and here also drug-induced, but here it is immune complex. So you don't have to remember all these things. It's rarely asked the causes of immune complex mediated vasculitis, but even if it is asked, I think it will be easy to pick up in terms of options. To write for a theory paper, it might be difficult to recollect, but as far as options is concerned, I think it should be easy to pick up. Okay. So the next 2 rare things are, one is paraneoplastic, one is inflammatory bowel disease. Okay. Now, paraneoplastic means, of course, it is associated with some cancer. So, carcinoma-induced vasculitis or lymphoproliferative neoplasm-induced vasculitis or myeloproliferative neoplasm-induced vasculitis. And inflammatory bowel disease also can cause vasculitis called IBD vasculitis. So, this is the same thing that we read in the previous slide. Now, coming to what is the renal involvement seen in each of these vasculitis? Like large vessel vasculitis, we know it involves the aorta and main branches, something like a Takayasu arteritis. So, if it has to involve the kidney, how it is going to cause? It is going to cause renovascular hypertension. So, we know that at the origin of the renal artery, it can cause some inflammation and renal artery stenosis leading to renovascular hypertension, right? Now, medium vessel vasculitis meaning it involves the visceral arteries and its branches. So, if we take the kidney, we know it involves from the main renal artery till the interlobular artery. So, glomerulus is not going to be involved. That's very important because it's not going to the glomerular capillaries at all. Now, here what can happen? See, it involves main renal artery to arcuate arteries, and most common is interlobar and the arcuate artery involvement. Okay, so sometimes interlobular artery also can get involved, but till interlobar artery and arcuate artery, these are the main areas of involvement. So here if there is inflammation and if there is thrombus, then you are going to see renal infarct and renal hemorrhage. Okay, so medium vessel vasculitis basically presents as infarct or hemorrhage. Now next, coming to small vessel vasculitis. Small vessel vasculitis is nothing but arterioles, capillaries and venules. So it involves the glomerular capillaries. So it causes glomerulonephritis. So the only vasculitis which causes glomerulonephritis is small vessel vasculitis. So this is very important. You remember last time there was a question in the last entrance, there was a question, I think it was INISS, there was a question of polyarteritis nodosa and a number of options were given. And the whole answer was based on the fact that polyarteritis nodosa cannot cause glomerulonephritis, right? Because there is no involvement of glomerular artery. Maximum it can cause renal infarction or it can cause renal hemorrhage. Now this is again how ANCA is classified. It's classified into pauci-immune, which is nothing but ANCA associated, which can be MPA, GPA or EGPA. And immune complex mediated can be because of immune complexes like SLE, rheumatoid arthritis. It can be because of cryoglobulinemia. It can be IgA. Okay. Now coming to our main focus, which is pauci-immune glomerulonephritis. So what does the term mean, pauci-immune? That is, in the immunofluorescence, you are not going to find any antibodies. Okay. So there are three major types in this. First is microscopic polyangiitis. Like we already discussed, there is not going to be any necrotizing granuloma in this condition. Second is granulomatosis with polyangiitis. Here the necrotizing granuloma is mostly going to be in the respiratory tract. Okay, upper respiratory tract involvement is rare. EGPA, eosinophilic granulomatosis with polyangiitis. Here the necrotizing granuloma is going to be associated with asthma and eosinophilia. This is also something we discussed again. So this can be either systemic or it can be renal limited, where we call it as renal limited vasculitis, where what happens is patient comes with RPGN, you do biopsy, you're going to find a pauci-immune glomerulonephritis. But systemically, they might not have any feature of vasculitis or ANCA might be negative. Okay, so in this condition, we call it as renal limited vasculitis. Now, what is the pathogenesis? We know that antibodies are directed against the antigens that are present in the cytoplasm of the neutrophils. Okay, so which are these antigens? We'll give it two shapes. So one is triangle, one is square. One antigen is PR3. The second antigen is MPU. Okay, now these are the two antigens. Now important is drug-induced ANCA-associated vasculitis. So there are four important drugs which can cause this. So I remember it with the mnemonic. Labor can precipitate PPH. Okay, labor can precipitate PPH. So what does L stand for? L stands for levamisole adulterated with cocaine. P stands for propyl thiouracil. Another P stands for penicillamine, and H stands for hydralazine. Okay, so that's the mnemonic. Labor can precipitate PPH. So levamisole adulterated with cocaine, propyl thiouracil, penicillamine, and hydralazine. So these are the 4 drugs. Now coming to levamisole associated vasculitis. So it is mostly in cocaine adulterated levamisole that we see. You see high titers of MPO ANCA, PR3 ANCA, and neutrophil granule protein elastase. So antibodies against all 3 things, MPO, PR3 and neutrophil granule protein elastase are going to be seen. Now next is most important thing to remember here is renal and lung involvement is rare. So if you're getting an MCQ that all of these are true about levamisole induced or drug induced vasculitis and they write that kidney involvement is common, then the exception in the options will be this. Okay, so because it's nephrology paper, you may not assume that kidney involvement is common, but still the examiner might think that you might assume. So don't be fooled, don't let them fool you. So it is the fact that renal and lung involvement is going to be rare in this condition. Okay, and mostly you're going to see leukocytoclastic angiitis and upper respiratory tract involvement in these conditions. Okay, so if not for kidney and lungs, you're going to see upper respiratory tract involvement or skin involvement. Now, this is the possible pathogenesis. So, you see this is an unstimulated neutrophil, right? Here you can see these are the blue color is the antigen that is going to bind ANCA. And here this is the FC receptor that is going to bind to the antibody. And here this pink color is nothing but the adhesion molecule. This is the neutrophil altogether. Now, what happens once a cytokine stimulation happens because of any reason? Then these antigens which are there, they move to the cell surface. Okay. And already these patients are going to have ANCA that is circulating in the blood, right? So this ANCA is going to bind to these antibodies like this, or the antigen which comes out can bind to the antibody and this will go and sit in the FC receptor of the neutrophil. So it can be either FC binding or the antibody binding directly to the ANCA antigen, causing neutrophil activation. So once this antigen antibody binds, the neutrophil is getting activated. Once neutrophil gets activated, the king, that is complements come. Okay, this complement is alternative pathway of complement. So that gets activated. Once this comes here, you see the blood vessel has started eroding. Okay, the blood vessel is injured and then the neutrophil migrates into the subendothelial space. Okay, once it comes here, there is apoptosis and necrosis of the neutrophils and the endothelial cells. So wherever endothelial cells are getting damaged, it shows you features of vasculitis. Like there's going to be necrosis, there's going to be, in the skin it's going to present as purpura, in the kidney it is going to present as glomerulonephritis. So this is the pathogenesis, as simple as that. Cytokine stimulation leading to neutrophil activation, the antigens come out, ANCA binds to it, neutrophil again gets stimulated, stimulates the complement. Once the complement also binds to this, it moves in the subendothelial space, destroying the endothelium, causing vasculitis. Okay. Now coming to the epidemiology, this is mostly disease of the elderly. It is seen in the 5th decade, 6th decade and 7th decade of life, with the peak incidence being 65 to 75 years of age. Okay. In India, you see MPO ANCA, that is myeloperoxidase ANCA, which is more common, and MPA being more common. So see, don't get confused between the diseases. MPA is microscopic polyangiitis. It's a type of ANCA vasculitis, but MPO is an antigen in the vasculitis. So MPO ANCA and MPA are more common in India when compared to PR3 ANCA or GPA, that is vaginous. Now clinical features here focus on which condition causes maximum involvement of which organ. For example, if you take microscopic polyangiitis, we see kidney is maximally involved, right? Rest everywhere it is seen, but kidney is maximally involved. Skin and cutaneous. So it's basically for 5 vasculitis: microscopic polyangiitis, vaginous, Church-Strauss, IgA vasculitis and cryoglobulinic. Okay. So kidney we discussed, it is microscopic polyangiitis. Next is skin or cutaneous involvement. We can guess it is going to be IgA vasculitis because they are going to present with rash and abdominal pain and the purpura which is in the extensor surfaces, right? Then coming to lungs. Lungs we can guess that GPA, that is vaginous, and EGPA, that is Church-Strauss, is going to be most common involvement. Ear, nose and throat. Again, we can guess that upper respiratory tract involvement is more common with Wegeners, and it's also seen in Churg Strauss. Musculoskeletal involvement is more so seen in cryoglobulinemia and IgA because they present with arthralgia and rashes. Neurologic involvement is more so seen in all conditions, but least it is in IgA vasculitis, but around 50% of all conditions. Gastrointestinal again will be more common with IgA vasculitis, that they are going to present with abdominal pain. Okay. Now, what are the features in each organ? What features it can cause? In the kidney, it will cause glomerulonephritis. So there can be hematuria, proteinuria, and RPGA. In the cutaneous, imagine the blood vessels in the cutaneous area are getting thrombosed or inflamed because of vasculitis. So there can be purpura. So these are mostly seen in the lower extremities and they appear in crops. Okay. In lesions forming granuloma like GPA and EGPA, there can be nodular lesions that are palpable in the dermal and the subcutaneous area because of dermal and subcutaneous arteritis. Next, coming to the upper respiratory tract, we know GPA and EGPA causes more than MPA. In MPA, you generally don't see granulomatous lesion. So only if granulomatous lesion is there, you can see nasal septal collapse. So nasal septal collapse cannot be seen in MPA. Okay. So other features that you can see in vasculitis with upper respiratory tract involvement is sinusitis, rhinitis, subglottic stenosis, otitis media, ocular inflammation. See, it is inflammation everywhere. It can be sinusitis, it can be rhinitis, it can be ocular inflammation, otitis media. In the vocal cord, it can be subglottic stenosis. There can be nasal septal collapse. Okay, these features. Now coming to the lungs, the alveolar capillaries can get involved in this inflammation and it can cause alveolar hemorrhage by pulmonary capillaritis. Nodular or cavitating lesion can be seen in granulomatous lesion like in GPA and EGPA. Okay. Cardiac disease in EGPA, there can be myocarditis. There can also be heart block because of inflammation. There can also be ventricular hypokinesia because blood supply is going to reduce to the heart. Okay. CNS, multiple nerve vessels and whatever blood supply to the nerves can get affected, causing mononeuritis multiplex. Gastrointestinal, mostly there is going to be abdominal pain, hepatitis and pancreatitis. Now coming to the most important part which has been asked again and again in exam, which is about anti-neutrophil cytoplasmic antibody. Now this anti-neutrophil cytoplasmic antibody can be detected by two techniques. One is immunofluorescence, other one is ELISA. Okay. In immunofluorescence, we have to notice that there is going to be many false positive. For example, if you take patients with inflammatory renal disease, like any disease having crescents, it might be anti-GBM, it can be some other vasculitis like SLE, rheumatoid arthritis, cryoglobulinemia, infective endocarditis. In all these conditions, there's 25% of false positivity by IF. And ELISA, if you see, only 5% there is false positivity. So ELISA is a better technique. So whenever you're sending for ANCA investigation, you should send by both, preferably if you have only one choice, ELISA. Okay. Now there are two types of ANCA which is going to be identified. One is PR3 and another one is MPO. So PR3 is C ANCA. So how you would have seen, right, the reports being reported as C ANCA, P ANCA, or positive for PR3, positive for MPO. So what is this C ANCA? What is this P ANCA? C ANCA is nothing but cytoplasm. The ANCA is the anti-neutrophil cytoplasmic antibody is seen mostly in the cytoplasmic area, right? So if this is the neutrophil, this is the lobule. So if you see it in the perinuclear area or in the cytoplasmic area, if it's in the perinuclear area, you call it as P ANCA, which is nothing but MPO, right? If it is in the cytoplasm, you call it as C ANCA or CANCA, which is mostly nothing but PR3. Okay. So there is a very funny way in which I remember this, which is P ANCA, which is C ANCA. I just remember P is not P. Okay. If it's confusing, just forget it. You can make your own way of remembering. But PR3 ANCA is not P ANCA. That's how I remember. PR3 ANCA is C ANCA and MPO ANCA is P ANCA. Okay. So this is mostly based on the location. So if you're going by IFA, you can detect it as C ANCA or P ANCA. If you're asking ELISA, you are going to get report in terms of PR3 or MPO. Okay. Now, ANCA testing has very good sensitivity, around 80 to 90% it is going to detect. 25% of patients with anti-GBM disease also are going to have ANCA positive. So, we call this as double positive disease, right? We dealt with this in the chapter of anti-GBM disease also. So, if you see the prognosis, this is very important. This has been asked in the exam in the AIMS paper. So, ANCA has better prognosis than ANCA plus anti-GBM okay. So, anti-GBM has a worst prognosis among these because it comes as a single effect or the single hit, and it's going to almost cause circumferential full crescents and it's going to destroy the kidney. But in ANCA and ANCA plus anti-GBM, this is lesser because it's going to be smaller and continuous insult. Okay. So this is important. Now 25% you see ANCA positivity in immune complex disease with crescents. So whichever immune complex disease like SLE, RA, whichever has crescents with more than 50% crescent involvement, in those conditions also you can see ANCA positivity. You can see ANCA not just in immune complex associated condition, in non-vasculitis conditions also you can see, which is in inflammatory bowel disease, in rheumatoid arthritis, in chronic inflammatory liver disease, endocarditis, cystic fibrosis. So it's okay, it's not necessary to remember this, it has been never asked, but it's always good to go through, at least you'll have an idea. So IBD, rheumatoid arthritis, chronic inflammatory liver diseases, endocarditis and cystic fibrosis. Now in GPA, you are going to see more of PR3 ANCA than MPO ANCA. In EGPA, you are going to see more of MPO ANCA than PR3 ANCA. In microscopic polyangiitis, it's going to be equal of both, okay. So GPA is more of, or vaginous is more of PR3 ANCA. EGPA is more of MPO ANCA. In microscopic polyangiitis, which is most common vasculitis affecting the kidney, it is both can be equal, PR3 and MPO. In EGPA, overall, you are going to see low frequency of ANCA positivity. So what I told here, I'll show it in the table here. So you see vaginous, PR3 is more in vaginous than MPO, right? In microscopic polyangiitis, here you see it's almost equal, 40 and 50. So PR3 and MPO are equally present. In EGPA or Churg-Strauss, you see that MPO is more common than PR3. In renal limited pauci-immune glomerulonephritis, it is mostly MPO that you are going to see, okay. So, renal limited is mostly MPO, and in MPA, microscopic polyangiitis, you are going to see equal of both antigens or antibodies against these antigens. Now, the clinical correlation of ANCA is highest with PR3, especially when upper respiratory tract involvement is there, like saddle nose. So, if PR3 is very high, then you are going to suspect that upper respiratory tract involvement can occur in this patient. For example, our vaginous granulomatosis or GPA. And these titer correlate with disease activity, but it is not dependable. Just because the titer is high doesn't mean that your patient has not responded to therapy. Okay, there are some cases where it responds to therapy also and still the titer is high. So the titer and the disease activity are not very interrelated. And 10 to 20% of patients can have ANCA negative. These patients are said to be that, see, any time when we are doing ELISA, there is going to be some epitope against which we are going to check, right? So, what they are attributing this ANCA negative cases as, there might be some other epitope, okay, for which this antibody ELISA testing is not there. So, epitope specificity is not there. So, we might be missing the antibody positivity, okay. Now, coming to the pathology, acute vascular lesion is going to be segmental fibrinoid necrosis. This is very important term. See, what is going to happen? Blood vessel is going to get invaded by neutrophils, endothelium is going to get killed. So here there is going to be inflammation, clot formation. So anything beyond this is going to die, right? So there is going to be some segmental. Now it's not like global. It's only few capillaries that are getting involved. So segmental fibrinoid necrosis is going to be seen, necrosis of this area. And here you can see there is going to be a lot of leukocyte infiltration, like I told, leukocyte infiltration. And these leukocytes can infiltrate the blood vessel also. So that is leukocytoclasia. We told that the neutrophil will go through the blood vessel only, right? So leukocytoclasia. So it's simple. There's going to be segmental fibrinoid necrosis, leukocytoclasia, and surrounding the vessel leukocyte infiltration. Now, if this involves glomerular capillaries, you call it nephritis. If it involves alveolar capillaries, there's going to be pulmonary hemorrhage. Dermal venules, it's going to cause purpura. Upper respiratory tract mucosal venules, it is going to cause rhinitis and sinusitis. Abdominal visceral arteries, it's going to cause abdominal pain. And epineural arteries, it is going to cause mononeuritis multiplex. Okay. Now, if there is a mild lesion, there's going to be segmental fibrinoid necrosis with a small crescent. But a progressive lesion, there can be necrotizing glomerulonephritis with full crescent. Okay. So, it starts with segmental and it progresses completely. Sometimes, if the interlobular arteries are involved and it causes involvement in the medulla. So, if you see the renal medulla, you remember that the interlobular arteries are going like this, right? So here, if there is interlobular arteries are getting involved and there will be medullary angiitis, then there's going to be papillary necrosis. But this is not common. Mostly we see glomerulonephritis. Okay. Based on the pathology that we see, we can classify this into 4 classes: focal, crescentic, mixed, or sclerotic. Okay. So it can be focal involvement, which is maximal or best survival rate, which is 93%. Next is crescentic, which can be 76%. The condition with least renal survival is sclerotic because everything is sclerosed. It's only 50%. Okay. Mixed, that is, it can be either focal or some can be crescentic. There can be some sclerosis also. This is intermediate between crescentic and sclerotic. So just because crescents are there, that doesn't mean that this is the worst prognosis, because crescents treated timely will respond. Okay. So you have to remember that mixed has worse prognosis than crescent. The best prognosis is focal lesion and worst prognosis is sclerotic lesion. Now, how will you differentiate between all these 5 vasculitis when patient comes to you? Okay. Now, how are you going to differentiate when a patient comes to you with vasculitis? Okay. So, vasculitis signs and symptoms can be seen in any of these conditions. In IgA dominant vasculitis, you see IgA dominant deposits, okay, which is not seen in other conditions. Similarly, cryoglobulin in the blood vessel can be seen in cryoglobulinemia and not in other conditions. ANCA in the blood will be mostly seen in these conditions, that is microscopic polyangiitis, Churg-Strauss or GPA. However, it can be seen in IgA and cryoglobulinic. Necrotizing granulomas can be seen in GPA and in eGPA. Asthma and eosinophilia is seen in Churg-Strauss. So these are the differentials that you can use to find which is clinical and biopsy, based on which you can classify the type of vasculitis. Okay. Now, coming to quick revision section, Chapel Hill classification, we know we classified it into large vessel vasculitis, medium vessel vasculitis and small vessel vasculitis, right? So large vessel vasculitis, further based on age, if it is more than 50 years, was giant cell arteritis. Large vessel vasculitis less than 50 years, which is necrotizing arteritis, was nothing but Takayasu's arteritis. Similarly, medial vessel vasculitis without involvement of mucocutaneous lymph node was polyarteritis nodosa. With involvement of mucocutaneous lymph node, it was nothing but Kawasaki disease. And again, small vessel vasculitis was classified into immune complex associated or ANCA associated. ANCA can be further classified into microscopic polyangiitis, granulomatosis polyangiitis or vaginus, and eosinophilic granulomatosis polyangiitis or Churg-Strauss. Sometimes drug induced also. Okay. And immune complex associated, most common types are SLE or rheumatoid arthritis, what is associated with cryoglobulinemia, what is associated with IgA vasculitis, and some other immune complex mediated diseases. Like it can be hypercomplementemic urticarial vasculitis. It can be infection associated, hepatitis B, hepatitis C. So this is the basic outline classification. Now renal involvement in vasculitis. We know that if it is large vessel vasculitis, then the involvement is going to cause renal vascular hypertension. If it is medium vessel vasculitis, because the blood vessels like arcuate and interlobar arteries are going to be involved, you are going to be seeing renal thrombosis, which can lead to renal infarction, or you can also see renal hemorrhage. Okay, so these are the findings that you are going to see. In small vessel vasculitis, what you are going to see is there is going to be glomerulonephritis. Okay, now drug-induced vasculitis, we read the mnemonic, which was labor precipitates PPH, right? So labor is going to be levamisole adulterated with cocaine induced vasculitis. P is going to be propyl thiouracil. Another P is going to be penicillamine, and H is going to be hydralazine. Okay. Now levamisole induced vasculitis, what is the specialty about this? It is mostly adulterated with cocaine. Kidney involvement is going to be rare, and most commonly you are going to see skin involvement, okay, in these patients. And there is going to be high titer of ANCA positivity. Now, most common vasculitis affecting the kidney, or most common ANCA vasculitis affecting the kidney, is microscopic polyangiitis. Okay. Vasculitis having granulomatous lesion, or ANCA vasculitis having granulomatous lesion, is granulomatosis polyangiitis and eosinophilic granulomatosis polyangiitis. What happens to immunofluorescence versus ELISA in ANCA? We know that immunofluorescence can have higher false positivity when compared to ELISA, and it can detect antigens in or antibodies in two ways. One is C-ANCA and another one is P-ANCA. The ELISA detects it as which is a specific antigen. The ELISA has lesser false positivity, only 5%, and here you can see that it is PR3, which is C-ANCA, or NPO, which is P-ANCA. So how do I remember it? P is not P. Okay, so C-ANCA will be PR3 and P-ANCA will be MPO. Okay. Now prognosis of ANCA versus ANCA plus anti-GBM versus anti-GBM. We know ANCA is better than ANCA plus anti-GBM, and the outcome of ANCA plus anti-GBM, or the double positive disease, is better than anti-GBM. Okay. Now incidence of C-ANCA and P-ANCA in MPA, we should know that it is equal, and C-ANCA is more than P-ANCA in GPA, and P-ANCA or MPO is more than C-ANCA or PR3 in EGPA. In microscopic polyangiitis, it is equal. Antigen in ANCA vasculitis with highest correlation against upper respiratory tract involvement and which can predict saddle nose is PR3. Okay. LM and IF, light microscopy and immunofluorescence findings in ANCA. Light microscopy, you are going to have focal necrotizing or fibrinoid necrosis. Okay. And you are going to see crescents. And immunofluorescence, you might not find anything, so that is why it is called as posi immune. Okay. Now, thank you friends. So this is the first section of ANCA. You can in the next part, that is in the schedule, in the next part you can also see the second section of vasculitis, where I'll be dealing with the treatment of vasculitis, which is large by itself, because there are a lot of trials, very important trials done in this, which can be asked in exam. So I will be putting a concise version of those trials, and also what is the treatment, current treatment followed for ANCA vasculitis. And also in the next class we'll be discussing about the different types of vasculitis other than that. So we'll have a small note about all the other types of vasculitis, which might be polyarteritis nodosa or Takayasu, and how it involves the kidneys. Thank you friends. I hope I helped you in understanding this topic. So meet you in the next class.